Welcome everybody. This is a session on all you should know about IUI, and we have a very dynamic speaker to start off with. And IUI is one of the procedures which I think most of us are doing. Knowledge on it is imperative. Those who are not doing it should also know how to deal with the patient of IUI. I think we should now go on to the scientific session.
Next slide. Can we have the next slide, please? So we have Professor Surveen Ghuman, who is the Director and Head of IVF and Reproductive Medicine Center, Max Multispecialty Hospitals at Saket, Delhi. She is also a Professor School of Health Sciences in Ansal University. Welcome, Professor Surveen, and I request you to please take the proceedings forward.
Thank you, Session. Thank you for the kind introduction. So, it is my pleasure to introduce Dr. Mala Srivastava. She is our dynamic president of AOGD 2021, a senior consultant and professor at Gangaram Hospital. She has many accolades to her name. She is a zonal chairperson of ICOPAP and a member of the governing council of ISCCP, secretary ISOPAP, Delhi chapter, executive member of IMS, and corresponding editor of Journal of OBS and Gynae of India, chairperson ISOPAP, quiz committee, ex-president Alumni Association of Gangaram, chairperson of Cervical Cancer Awareness and Prevention Committee of AOGD, joint secretary IMS, executive member of ISCCP, and many more. Also joint secretary Nachi Delhi branch. I welcome you onto this webinar on IUI, Dr. Mala. Request you to please start the session and introduce Dr. Kuldeep.
Thanks, Dr. Surveen, for your nice introduction. I'm very happy to be associated with this webinar, which is conducted by Dr. Kuldeep Jain as well as Dr. Surveen. Without wasting any time, I would like to introduce our speaker of the day. Dr. Kuldeep Jain requires no introduction. He is a senior IVF consultant and gynae laparoscopic surgeon and currently director of AJ IVF and Laparoscopic Center. He was formerly reader at UCMS and GTB Hospital, Delhi, and professor at Muzaffarnagar Medical College, and having more than 30 years of teaching and clinical experience. He is trained in ART, embryology, and completed his fellowship in ART and KK IVF, Singapore. He is one of the pioneers for establishing the teaching and training courses in reproductive medicine and embryology in India, and was instrumental in starting the prestigious embryology preparatory course for HTA exam and IFS certification for embryology. He has FOXY for last 35 years in different roles actively as chairperson Endometriosis Committee 2017-2019, and he has been member of various committees, PCOS, ovulatory disorders. Now he is your candidate for President FOXY, Vice President FOXY this year. Also founder, secretary and past president of Indian Fertility Society and editor-in-chief Fertility Science and Research. He has established one-year diploma in clinical embryology run by Indian Fertility Society in collaboration with MIT University. He is currently scientific committee member of International Federation of Fertility Societies. He has written multiple chapters and authored many books. He has delivered more than 200 lectures, notes in national and international fora. Welcome, Dr. Kuldeep. We are all waiting for your excellent deliberation on all we should know about IUI. Over to you, Dr. Kuldeep.
Thank you, Dr. Mala, for kind words. It is a difficult time. Everybody is disturbed because of the corona and pandemic, and I am happy that we are able to share the knowledge during this difficult time also, and for that I am very thankful to Dr. Mala, who is president of AOGC, for giving us this platform to connect each and everyone So congratulations, Dr. Mala, for your freshly acquired presidentship of AOGD, and I wish you a very successful tenure. Uh, I am also thankful to Science Integra and Bharat Serum for providing all help in arranging this webinar. My topic today is a very pertinent topic. IUI everybody is doing, and whenever we meet people during the conferences, there is always uh, one question that I have been doing IUI for last so many years, but I am not very happy with the outcome. So that is very common question. And today, what I am going to take you through next 20-25 minutes is how you can optimize your IUI program. Because that is one thing. If you observe the recommendation as well as the tried methodology, then you can certainly improve or optimize your IUI outcome in your program. So can I have the screen share?
You will have to do the screen share.
Yeah. So before I start my talk, I seek your support for my candidature as Vice President Foxy North Zone. I hope everyone is aware that the Foxy election are coming in August, and I seek your patronage and support for Vice Presidentship to serve Foxy in the bigger role. Intrauterine insemination, evidence-based guidelines for practice. That is what I am going to share in next 25 minutes. Of course, I will be sharing my experience. I started my IUI program almost 30 years back, and now I can share some of the difficulties and how to overcome these difficulties in your program. Now, coming on to the basic principle of IUI, if you understand the basic principle, I think 50% battle is won. What is actually the rationale of IUI? It is to expose more oocytes to more sperm near the site of fertilization at the right time to increase the chances. So this is, if you keep this thing in mind, there are three things. You have to increase the number of oocytes. You have to increase the number of motile sperm. You have to deposit them high in the uterus near the site of fertilization at the correct time. So these four things, if you keep in mind, I think you can optimize your program. One more thing I will like to highlight here, that IUI is a very simple procedure. So always keep it simple. If you follow this rule, then you can certainly get a better outcome from your IUI program. Now, what is important? Proper patient selection is very important for successful IUI outcome. If you have not selected the patient properly, then whatever you do, you may be having a very good lab to you must maybe having a very good embryologist who can give you very nice harvesting of sperm, even in a poor sample. But if the patient is not properly selected, you cannot get pregnancy in that patient. So that's why it is very important to select patient for IUI. I will go into little detail. What do I mean by proper patient selection? Then, of course, there is individualization of induction protocol. Again, there are a lot of concerns whether it can be done in natural cycle or induced cycle. Because literature, you will find natural cycle also IUI is done. But when we talk of optimization of IUI program, you have to keep in mind that rationale that you have to increase the number of oocyte, available oocyte in that particular cycle. Third thing is timing of insemination, again very, very important. And you should know when to stop. If your IUI cycle is failing again and again, you have to look back and try to see why you are failing. So, and then take decision whether the IUI program which you are offering to the patient is right choice or you have to move on. So what I am going to cover today is selection of patient, how important, natural versus stimulated cycles, CC or HMG, is there any role of agonist or antagonist, influence of the number of follicle on outcome, this is very important, timing of IUI, single or double IUI, semen collection, IUI interval, is it important, which method of sperm selection, luteal phase support, is there any evidence, how many cycles of IUI to be done, and when to say no for IUI. So these are some of the points I will be highlighting. Now here one caution I will like to give. Whatever guidelines and recommendations are available at this point of time, there are always argument against the guidelines. So one has to keep in mind a individualized approach in
Can't hear him.
Can't hear him.
Can't hear him. I think he has muted himself.
He has muted his, he stopped his video as well as muted.
Yes. Can somebody ask him?
He has stopped his video and he has muted himself.
Yes. The touch screen में कुछ
Dr. Surveen, we can't hear him.
So I'm trying to call it. अच्छा, then just reconnect again because वो आ नहीं रहा. He got disconnected. He's connecting again.
Yeah. We can have water break.
It's very hot.
Hello.
Yes.
Yeah. Dr. Kuldeep is just joining. He has not disconnected. So everybody, please just stay on, and it's just going to take a minute for him to do that.
Right.
yeah. So now my slides are visible.
Yes.
Yeah.
Yes. You are visible, sir, now.
So,
You're audible also.
but my slides are not moving. Let me see why.
You can share it again. Unshare and then share.
Yeah, you have to. I think session you have to give the permission to share.
Can't hear you.
Here it is coming like you cannot start screen share.
So you can start right now.
Okay. Okay, so can you see now? Yeah.
Yes.
So age is very important, and if your patient is young, certainly you are going to get a better outcome. Patient should be capable of spontaneous or induced ovulation. Again, very important. At least one one patent fallopian tube with good tube-ovarian relationship. This is again very important. See, tube may be patent, as in endometriosis, but if the tube-ovarian relationship is disturbed, then again that is not a very ideal patient for your IUI program. Sperm count more than 10 million pre-wash or 5 million post-wash is ideal for IUI program. In literature, you may find that even 1 million post-wash sperm can go for IUI. But my experience as well as other people's experience is you should always have a cutoff for your program. If you are taking patient with severe male factor, your IUI results will always be poor. So that is not a very proper selection of your IUI patient. And of course, you should be accessible uterine cavity able to negotiate it. Now, these are some situations which you have to keep in mind where IUI may not be very helpful. Like if patient is having a tubal factor, you have done HSG and there is some doubt, please don't consider this patient for IUI. First, you rule out the tubal factor and then go ahead. Otherwise, you may not get a very good success in your IUI program. Severe male factor, I have already told you, it is very, very important. People keep on doing IUI in severe male factor. That is not a very good choice. Endometriosis, grade 1, grade 2 is okay. That comes in the recommendation. But when it is grade 3, grade 4, it is not a very right choice for these patients. Then, of course, tuboperitoneal factor and elderly female. So these are some of the conditions which you should keep in mind before considering IUI. Prognostic factor, female age is again, I am highlighting it again and again. Age is very, very important and it decreases progressively. As the age advances, the success rate are going to decrease. So your expectation and counseling goes a long way. You have to counsel your patient. Even if you are taking a patient of elderly age like 38 years, you have to counsel the patient what is the expectation. If in that patient, if you are expecting or the patient is expecting that you will have a very good result, I don't think that is a right way to go ahead. You can see this figure is very, very important. Cycle fecundability less than 35 years, around 20%. When you move up, it is almost half. And then when you move more than 40, again, it is half. So this goes in counseling. Whenever you are counseling, this slide should go in counseling. This is a very, very good slide. Age with cycle fecundity. And here you can see the maximum fecundity in this age group. And when the age advances, it goes really down. Another thing is relationship of motile sperms available with the pregnancy rate. And again, you can see if you are having only 1 million sperm, almost zero fecundity, and as it progresses, so ideal is at least 5 to 10 million sperms should be available for insemination if you want to optimize your program. Cause of infertility is again related, like overall pregnancy rate. If you see, higher pregnancy rate are going to be seen in unexplained infertility and ovulatory dysfunction. So these are two groups where you can expect around 15 to 20% fecundity per cycle. But in cervical factor, previously we were thinking that cervical factor is another very good choice. But here somehow, maybe because of immunological or something like that, cervical factor usually doesn't give very high fecundity. And of course, poor fecundity is seen in endometriosis, immunological infertility, and severe male factor, moderate to severe male factor. When we talk of male factor, if you are doing donor insemination, again the fecundity increases. So donor IUI are always giving a high pregnancy rate than using a ejaculated sperm from the husband. So that shows that male factor per se is not a very good indication for IUI. Now coming on to the stimulation regime, as I told you that IUI is a simple procedure. So let us keep in mind that we have to keep it very, very simple. We always start with oral ovulations in IUI program, but because of the restriction of the number of cycles you should provide, you should not stick on to the oral ovulation only. That is what message I want to give. So always, usually we start until unless there is some contraindication or patient previous ovarian response with oral ovulation was not very good. Then you can directly move on to the gonadotropin. But otherwise, first cycle is always a oral, whether you are using clomiphene citrate or letrozole. And if there is a satisfactory response, you can go for a second cycle again with oral, but not more than 2 cycles. If your patient is not conceiving, in spite of having a very good endometrium and very good response, patient is not conceiving, then you have to review your stimulation protocol. What we recommend is the use of least expensive medication for IUI program. Again, because it is a simple procedure, you are doing it again and again. Fecundity is not that very great, so you have to minimize the cost also. Now, what is the optimal stimulation for IUI? This is a paper by Omelette, and this sums up 2 to 4 follicle. Now, here I have put a query. 4 is slightly higher, so I will say it is 2 to 3 follicle of 18 to 19 millimeter. That is optimal stimulation. If you are having a single, I will show you the slide. If you are having a single oocyte, what is the pregnancy rate? And if you are having 2 follicles or 3 follicles, what is the pregnancy rate? Then, of course, we don't do any E2 level in IUI program, but if you are doing, then certainly this can be. So this is theoretical part. Usually, we don't recommend any measurement, hormonal measurement in IUI program. Endometrial thickness is again very important. If you are having a 8 to 10 trilaminar endometrium, it is a good prognostic sign. IUI done between day 13 day 16. Of course, this is not absolute, because in anovulatory patient like PCOS, this may go beyond 16, but it is ideal. You are doing IUI on 13 to 16 day. And of course, cancellation are there, and one should consider cancellation if you are having multiple eggs. Now, what are the factors which influence ovulation induction? Again, very, very important, female age. The same medication you are prescribing to a younger patient, you will get a very good response. So, age has to come into play. Ovarian reserve, again, if it is a poor reserve, you have to change your protocol. And then if the patient is obese. I will not go into the details of various protocols, because they are always discussed. But what I am going to discuss, what is ideal in what situation and how you should switch over to different protocols. So as far as the clomiphene citrate is concerned, it is a great drug, but however, because of the problems and the discrepancy between the ovulation and pregnancy rate, it has now gone into backseat. What is cutting corner regime? Usually we because we are aiming for 2 to 3 follicle, so we don't start with 50 milligram. We don't give 150 milligram. So we have cut the corner on both sides. So you start with 100 milligram. If your patient is having a good response, go ahead. If not having good response, next cycle you change the protocol. So that is what is the cutting corner regime. Letrozole is now actually has replaced clomiphene in almost 80% of the cycles. So that is a very good drug, which is again a oral drug. And how letrozole is different from clomiphene, it mimics CC without depleting the estrogen receptor. So that is main important thing. It is having a short half-life, and there is no down regulation of receptors. So you can add on the gonadotropin, they will work better. There is no peripheral suppression of estrogen. So endometrium comes very nice, though the total estrogen level will be low. Gonadotropin, usually when we are dealing, because almost 40-50% of the patients, they are PCOS subgroup. Okay, So there, if you are using gonadotropin, your clomiphene letrozole has failed, you have already tried, then usually we do the low chronic low dose step up. I I will not go into the detail, but usually what we do, we are not following the original chronic low dose step up because that takes very long. Okay. Maybe sometime it may take more than 20-21 days. So to reduce that, we can go for a modified chronic low dose program. There the increase in the dose is little faster. So instead of 5 to 7 days, we are increasing the dose maybe 3 days to 5 days. So that reduces the chance of OHSS. At the same time, gives a better harvesting. Another protocol which is suggested is the sequential step up, step down. But here again, risk of OHSS increases. So it is not very favorable protocol. But if your patient is not responding with the chronic low dose, then you can plan to increase the dose in beginning. And then once the follicle is selected, you can step down. This is a very favorable protocol for IUI. Here what we are doing, we are combining the letrozole with gonadotropin. This works in two ways. You are reducing the number of ampule of gonadotropin. At the same time, you are having a multifollicular response. You can titrate the gonadotropin dose in a better way. So it is very effective in resistant cases. It is cost effective, gives better endometrial growth and comparable conception rate when you compare with pure gonadotropin protocol. So this is very favorable protocol for IUI. Now, whether we should induce all patients. Your patient is ovulating, why to induce? This is always a question. But if you go into the rationale of IUI and how to optimize, we should always have more than one follicle. It is not like your patient will not conceive if you are having single follicle, but the fecundity will be low. So this is some data which I am presenting. You can see the success rate in natural cycle versus the clomid cycle versus the gonadotropin cycle, and you can see 19%, 26%, 38%. Of course, this is one paper. 38% is a little high figure. Usually we don't get this. But certainly if you compare natural cycle versus CC versus SMG, there is a graph like this. So conclusion, you can say human menopausal gonadotropin stimulation results in a significant optimization of IUI program. One should always consider. This is another Cochrane database. Gonadotropin are most effective when you combine it with low dose protocol or a combination protocol. This is another review, and they concluded that unstimulated IUI does not significantly increase the pregnancy rate. So there are a lot of reports which say that only timed intercourse or IUI, there is not much difference. Though there is a slight increase, but statistically it is not significant. And when you do the IUI with stimulated cycles, all reports they have shown that there is a increase in pregnancy rate. Now this is again 2009 data, S-ray Capri workshop, and here again you can see IUI plus CC pregnancy rate 7%, when it is done with gonadotropin 12%, and when you are doing it with the combination, again almost same. So that is in support of stimulated cycle. Now another question which always comes in mind, if you are using gonadotropin, whether it should be urinary recombinant, again I will like to say, as I have said, you have to keep it cost effective. If you are using recombinant, certainly the purity aspect comes, but as far as the results are concerned, there is not much difference, especially in IUI. So you can use urinary or recombinant, whatever your patient can afford. There is not much difference. Theoretically, yes, recombinant products are more pure and can be used. This is our data, and here you can see CC cycles. This is a large data of almost 3,000 plus patients, and here you can see when we use CC alone, it is 9.1%. When we combine CC plus HMG, it is 18%, and when HMG alone, it is 23%. So you can see here, this is the first-hand experience which can guide you in making your choice of stimulation protocol. This is another paper on combination, whether CC plus FSH is better or same as letrozole FSH. And here again you can see letrozole plus FSH is better than CC plus FSH. And here almost the rate are same whether you are using gonadotropin alone or a combination with letrozole. And here you can see the dose is almost half. When you are combining with letrozole, the dose is half. The risk of OHSS will always be mild. Again, this is our experience. We have published this paper in 2005, and you can see letrozole cumulative pregnancy rate 13.8%, combination 20%, and FSH 21%. So here again you can see by just combining letrozole, you can get a almost same outcome in these programs. This is again a Cochrane review 2012 saying the same thing. Expectant, no treatment, hardly any pregnancy rate, and natural cycle, you move on and you go increasing the pregnancy rate. Now another question, influence of the number of follicle. What is the influence of number of follicle? One follicle, IUI success rate are 3, 4, 8% in different studies. Two follicle, 9, 13, 21%, and 3 follicle, it increases to 16 to 24%. 4 follicles, again the pregnancy rates are very high, but the chances of ovarian hyperstimulation syndrome is also very high. So this should be the cutoff, 2 to 3 follicle if you want to optimize your program. This is another large meta-analysis of almost 12,000 cycles, and they also said that multifollicular growth is associated with increased pregnancy rate in IUI. This is our statistics. You can see almost 3,000 plus cycles. Number of follicles, 1 follicle 9.4, 2 follicles 14.6%, and 3 follicle 21%. So what we plan is always 2 to 3 follicle. 4 follicle usually we don't, usually we cancel, but in some of the patients we do with all risk in mind, and you can see the pregnancy rates are almost same, but the multiple pregnancy and OHSS is higher when you are having more follicle, so that you have to keep in mind. What is the best time of insemination? Always a debatable issue. Now this is again from Esray workshop. The timing of IUI in majority of the published literature is 32 to 36 hours post SCG. So one has to time the IUI, and best way of timing is a ovulation trigger. You can use urinary LH or other methods, but best way to time the IUI is SCG trigger. Single or double insemination, again a debatable issue. Now here you can see the impact of number of insemination. There is no significant difference whether you are doing single IUI or double IUI. Usually there is no difference. It increases the cost. It is not required in all cases. What is required is the timing of IUI, which is related to your ovulation trigger. And this study concluded that single IUI timed post-ovulatory gives a better success rate. If the follicle has not excluded and you have done a IUI, the chances of success are slightly less. when the ovulation has occurred, this is one paper which I am quoting. There are many other papers who have quoted the same thing, but this is a subject for randomized control trial to reach to a conclusion. Again, this is a meta-analysis. Almost same are in favor of single IUI and others are in favor of double IUI. So there is no significant difference between single and double insemination. Additional prospective studies are required. That was the conclusion of this paper. Our experience, usually in our center, it is single insemination. We do double insemination only if ovulation has not occurred at the time of first insemination. So we call the patient next day, and if the ovulation has occurred, we do the second insemination, and that optimize the resources basically. If on second day also there is no ovulation, usually double insemination doesn't help. So individualized approach is required. You should not go blanketly that I am doing double insemination or I am doing single insemination. It is the individualized approach. If your patient has not excluded, you call the patient next day, and if there is ovulation, you can go for a second insemination. Otherwise, single insemination is sufficient. Selecting the motile sperm again is very important field, but how relevant it is, we just see. It is an important step for successful outcome. There are various methods. I am not going into the detail of various methods, but what is required, how do you select? What is the aim is maximum yield of morphologically normal motile sperm without seminal plasma, pus cells, debris, and minimal DNA fragmentation. So that is the aim of selecting the sperm. Ideal sperm preparation technique, it should be fast, easy to perform, and cost effective. Should give maximum yield of functional motile sperm, should not cause sperm membrane damage, and it should eliminate ROS activity as well as dead sperm. So these are the ideal characteristic of, you can use single centrifuge, you can use swim up, you can use double density, depending on the initial sample. If the initial sample is good, you can do the swim up. If the initial sample is compromised, usually the double density gives a better harvest. If it is very, very bad, then it is not the sample for IUI. So that you have to see on that day what type of sample has been produced, and you can decide on the method which is to be used. Usually the method do not increase the success rate. It is the sample and what you are producing, harvesting, that will decide the success rate. What is good sample for IUI? When you are doing again in post-was or post-thaw semen analysis, concentration and motility seems to be the most important variables. So total motile sperm count, this is post-was sample. Less than 1 million if you are having, then the pregnancy rate are very, very low. More than 1 million, again, it is 5 to 6% only. And when it is more than 5 million, 11.8%. So as the number of motile sperm goes into the sample, your pregnancy rates are going to be better. Motility, again, same. If it is less than 20%, very poor result. More than 20%, it may increase, and more than 50%, it is ideal sample. So at least more than 50%, more than 5 million sample is supposed to be a proper sample for your IUI program. Now, how much delay is allowed? Again, this is very good study. Collection of semen to the insemination interval is also linked with the optimization. And they say that 90 minutes is the time frame. So after collection, within 90 minutes, you should be able to inseminate to get a proper outcome. Usually what happens, you are not having a lab, you have sent the sample to some other lab, and the time elapses almost 2 hours, 3 hours, and when you are getting sample, whatever protocol you have used, it is not of any use, and that cycle goes waste. So this is very important. Uh, Luteal support actually is again a debatable issue. Limited data exists concerning the need for luteal support in clomiphene citrate cycle, but the addition of progesterone we have been using in practice, and it is one of the established norm. Literature may say otherwise, but it is there is some support in the literature that luteal support helps in optimizing the cycle. This is one paper, 214 patients, 427 IUI cycle, and they found that progesterone vaginal gel gave a higher pregnancy rate, 35 versus 18%. So where this is randomized trial that supports use of luteal phase in IUI program. Even live birth rate was very highly significant when the progesterone support was used. Another paper, you can see again, live birth rate is almost 3 times when you are using a progesterone support. So I am also in favor of progesterone support in IUI program, though the literature says that clomiphene citrate, because see, there is some element of some, in almost all patients, a element of defective folliculogenesis. LPD is very difficult to diagnose, so it is always good to support luteal phase to improve or optimize your program. These are various papers. I will not go into detail, and they all are in favor of luteal phase support. How many cycle? Very important question. And now it is recommended that beyond 4 cycle, if you have to go for IUI, you have to think 100 times whether the 5th cycle is required, whether you are going to help with that 5th cycle to that patient. So after 3 cycles, failed cycles, you should start thinking whether you are going to provide a 4th cycle. And after 4th cycle, yes, that you have to take a call. So maximum number of IUI cycle should be not more than 4 cycles. For donor insemination, you may go up to 6 cycles. But in all other indications, 4 cycles is the limit. You can see this nice graph. The fecundity rate increases with the number of cycles, and this is the cumulative pregnancy rate, and then it goes down in 5th cycle and 6th cycle. This is my final slide. These are some of the evidence-based recommendations. The goal of ovarian stimulation should be the development of maximum 2 dominant follicle. No sperm washing technique is superior to another method. Most reports recommend a single well-timed IUI in couples suffering from unexplained infertility. However, in male factor, double insemination may be recommended. Optimal time interval between SCG injection and IUI insemination is 36 hours, and at least 10 to 15 minutes of immobilization should be applied before for every insemination attempt. There seems to be no place of agonist or antagonist in IUI program. Again, there may be debate whether the usually we keep it very simple, so we don't go for any agonist or antagonist. And cutoff of total motile is anywhere between 5 to 10 million. At our center, it is 5 million. Every lab, every center may have a different cutoff, but certainly it should not be less than 5 million. So concluding, it is a IUI is less invasive and cheaper than other complex ART treatment. So it should be given a place, and it should be used judiciously with individualized approach. And whatever I have elaborated, these are some of the recommendations which is coming from the literature with almost 50,000 cycles literature we have researched, and they might help in optimizing your program. So with this, I conclude my talk. Select patient carefully, keep records, analyze them. That is very important. After each failed cycle, you have to analyze why your cycle failed and then plan the second cycle. And until unless you are keeping a record, you cannot analyze them. So record keeping is very, very important. Do everything, try to do everything under one roof. That will again optimize the program, whether you are doing a stimulation, IUI or IVF. If all facilities are under one roof, you can just certainly double your pregnancy rate, and you should know when to stop. And I have already told you that after 3 cycles of IUI, you have to start counseling. If the patient is severe male factor, maybe after one cycle, you can just move on to the IVF. If the patient is having grade 3, grade 4 endometriosis, you have corrected it very nicely. You think that IUI may be helpful. Still, not more than 2 to 3 cycles of IUI, you should move ahead with IVF. So with this word, I will close. I will take up the question. If there is any question here, I can answer.
Yeah, there are 3 questions.
Yeah.
That was an excellent lecture, Dr. Kuldeep. You've left nothing for me to discuss. Okay, so the first one is from Dr. Vaishali Jain. Any changes we have to do for our infertility practice, especially in IUI due to COVID pandemic?
Yeah, very, very pertinent question. Actually, we are planning a full webinar on post-COVID scenario, how to start our practice. We have already come out with a lot of guidelines. A combined task force was prepared, IFS, ISAR and ACE, and they are now released. So please go through, whether you are doing IUI or IVF, you go through these guidelines. They will be really helpful. As far as the change in practice is concerned, COVID has changed the scenario of practice, yes. Lot of consultation now we are doing on online teleconsultation. So call your patient only when it is required. That is first change in your practice. Okay. Ask the patient to send all the reports online, screen the reports, and try to minimize the visits. And whenever you are calling the patient, ask the patient to come alone or only with one attendant. Not more than one attendant should be accompanying. That is another change in the practice. Then, of course, all norms of social distancing and we have formed actually triage form for all our patients, which needs to be filled before they enter into our clinic, and they are all patients are by appointment. So they are sent this triage form on WhatsApp or online, and once the risk assessment is done, if they are low risk score, then they are called. If they are middle and high score, usually they are advised to avoid the procedure in that month. And testing of the COVID for IUI program is again discussed. Semen has been reported to harbor the infection, but that report is actually 16% semen samples were found to be positive for COVID. But that cohort was all positive cases. So we don't know that in general population whether all patients should go for COVID testing. But sooner or later, the COVID testing is going to be included in all, even with semen analysis. Like we are doing HIV, so it will be done for COVID. But at present, for IVF patients, we are doing for all patients. But for IUI, we are trying to avoid calling them. Okay, because we have to keep IUI very simple. So you can delay IUI if the score is high. Rest of the thing, universal precautions you have to take to avoid and to keep your staff safe and yourself safe and your patient safe. So these are the changes. Otherwise, protocols, etc., there is no change.
There's another question from Dr. Seema Tripathi. Kindly throw light on abstinence around IUI. Is it required? How much?
Again, very important and very good question. Usually, what happens when you start any program, whether you start IUI or IVF, patient stops having sexual contact. Okay, and if you have not given the instruction, then on the uh, day of IUI, you will have a sample with 15 days abstinence. So that is not very good. Older sample will always have a poor motility, high ROS, and it will be a poor quality sample. So usually the abstinence should not be more than 1 day. So what we practice on the day of ovulation trigger, we ask the patient to have intercourse. Uh, Next day abstinence, and third day IUI. So that is what the practice.
Okay, then there's Rachita Chawla. Does the day of trigger matter if follicle has not ruptured post HCG trigger? If we give a repeat trigger, like can we give a repeat trigger and not consider the first trigger?
Usually the repeat trigger doesn't help. I don't practice, but there are some reports that some people do give a second trigger, but the recommendations are it doesn't give you a added advantage. So once you have given the trigger, it should function. Otherwise, you have to change your protocol.
Okay. Dr. Shanti Guna Singh has asked two questions. In combined therapy, how do you decide the dose on gonadotropin 75 or 150? And the second question is there a role of estrogen tablets anywhere in IVF?
Yeah. So as far as the dose of gonadotropin is concerned, it is always with 75 uh, when you are combining, and usually that works in almost 90% of the patients. If your follicle is not satisfactorily growing, then you can increase 150, but most of the patients it is 75. As far as the estrogen is concerned, adding estrogen again, it may increase the endometrial thickness, but as far as the fecundity is concerned, it doesn't work. So that's why it is not recommended. It is better to change the protocol in the next cycle if you are having a poor endometrium.
Okay, so Dr. Lata Agarwal has asked, sometimes USG shows no rupture of follicle, but pregnancy occurs in the same cycle.
Yeah, that is always possible. That is always possible because you have done IUI and there was no follicle rupture, but after IUI you are done, you have not followed that patient, and the rupture has occurred. So your IUI or the normal intercourse may also lead to the pregnancy in this cycle.
And I think sometimes after rupture, the follicle refills. So when you're doing an ultrasound, you actually find it like a follicle.
Yeah.
Then there is a question, should we do IUI in COVID days, Dr. Meera Gupta? And Dr. Suman Lal has said, is COVID test mandatory for patients going through IUI?
I think I have already highlighted that point. IUI can be done in COVID days, but you have to take all precautions which I have highlighted. And doing COVID at present, actually the government guidelines are not such that asymptomatic patients should go for COVID. So they are the ethical, legal restrictions. But suggestion is there that any patient who is giving the semen in your lab should be tested positive. Basically, husband wife both should be positive. Ideal situation is that. But for IUI, you may delay it rather than spending money 10,000 on COVID testing.
So Dr. Meera Gupta has asked again, is there any role for arginine and sildenafil? This is Dr. Shanti Guna Singh. And in case there is an unruptured follicle next day after IUI, what should be done, Dr. Meera Gupta? So arginine and sildenafil.
Yeah, arginine, sildenafil are adjuvant. Basically, they are used to increase the vascularity. Uh, there is no definite role as far as the IUI is concerned. There are few reports which have shown to increase the uh, vascularity, but as far as the fecundity is concerned, there is not much difference. So it is always arbitrarily used, depending on the previous failures, previous response. And what was the next question?
The next question was, is there, in case there's an unruptured follicle next day after IUI, what should be done?
We don't do anything. You just leave the patient, ask the patient to have contact that day, maybe next day, and that might work. Otherwise, you have to review the for the next cycle.
So last two questions are, Dr. Usha Mukhi, what about intercourse on the same day after IUI?
Yeah, that is okay. There is no restriction. There is no restriction on that.
And Dr. Rachita Munjal, can tamoxifen be used for IUI stimulation?
Tamoxifen is one of the drug which has been suggested, but in my 35 years, I have not used. You can use. There is no contraindication, but we are having better drugs and better available drugs, so certified drugs. So that's why tamoxifen. Usually, most of the people are not having. See, letrozole. Once the letrozole came, the scenario has changed. CC was there, then if the patient is not responding to CC, tamoxifen was used. But now you are having a better oral ovulation. So instead of tamoxifen, you can use letrozole. That will be better.
I think I did use tamoxifen when letrozole was banned, and it did
Yeah.
give a good endometrium.
Yeah,
But
you can use.
otherwise, it's not actually recommended for ovulation induction as such.
Yeah.
Can I make a point here?
Yes,
Yeah.
yes.
Yeah.
This was a very exhaustive, comprehensive, and informative session. But one thing I want to say, there are some profile of patients who switch over from one doctor to the other,
Yeah.
and they hide their history as well. Because we came across 2 or 3 such patients. They were young, 32, 33-year-old. They must have had, when they took the history, they had 18 IUIs. IUI done 18 times, and they landed up with ovarian mass. And when we did laparoscopic and ovarian cystectomy, it turned out to be borderline ovarian tumor.
Yeah.
We had 2 or 3 such patients, and then we dig the history. Then they told they had switched over from one IVF specialist to the other IVF specialist, and they have hidden their history, and they have not come out with the true history. So and though the patient was very young, she was 33-year-old, and we got 2 or 3 such profiles. So we have to be very careful when we are taking these patients, high profile patients, professionals, educated, but then they come up with such histories and they hide the history from their treating professionals. So once when you say that only 4 IUI should be done, so that should be taken as a serious matter, and we should not go on doing IUI again and again to these patients.
Yes, very, very rightly pointed out, because and that's why I said you should always ask for the previous reports. Patient may not be having, you go little deeper, you may come out with the answer that patient has already received the few cycles of induction, and there from there you take onward what type of induction is to be given, how much to be given, and how many cycles to be given. So that is very, very important observation. Yeah.
Sometimes these patients, they hide their history from different doctors,
and
they land up with something like 18 IUIs, and that was not comparable. You know, if a doctor knows that this patient has so many IUIs, they will not do it.
Yes, certainly. Any other questions, Surveen? Surveen, can you hear me?
Unmute yourself, Dr. Surveen.
So this is a question, 33-year-old primary infertility, AMH 0.32, FSH 10, on HMG 75. She has monofollicular growth. There is a small fundal fibroid touching the endometrium. Is fibroid of concern? And in this patient, how do you get 2-3 follicles? AMH 0.32.
So, no, what is your plan? Actually, you have to plan it before asking this question, because before inducing this patient, you have to do a lot of homework whether this patient requires this type of induction or something else, and what procedure you are planning. IUI in this type of patient should not be planned, number one, because he is already poor reserve. Uh, what you are seeing, the AFC, AMH, so you should always take into the account. It is not only AMH. You should do a basal scan to see the AFC, and of course, age comes into picture. So these three things has to be kept in mind before starting any ovulation induction in these patients. And these patients, they should be counseled, even if the patient is young, maybe 24 years, but the patient is having very poor AFC at 0.3 AMH. Patient should not be started for IUI program. That is number one. Second, how to get more eggs in this. There are many regimes. People have tried protocols for these patients. And if you are having 3-4 AFC, then 0.3 AMS should not worry you. You can go ahead with your preferred protocol to get at least 2-3 follicles. You have to start little higher dose. I am in favor of higher dose. People may say that natural cycle can be done or something like that. But when you are planning IVF, usually we start with little higher dose in these patients, and they are delayed. The antagonist protocol is there that also gives a better harvesting. So there are multiple protocols for IVF, but for IUI, usually this patient should not be considered. Second thing, fibroid. Subserous fibroid doesn't cause much concern to uh, go ahead. But if it is a intramural fibroid touching the endometrial lining, or it is a submucous fibroid, then of course you have to take care. But subserous fibroid should not be of a concern.
Okay, I think we finished with the questions,
Yeah.
and thank you, Dr. Kuldeep, and request you to stay on for the next session so that we have your valuable comments.
Thank you. Thank you, everyone.
So, it is my pleasure and honor to introduce an esteemed panel. Dr. Manju Puri, she is Director Professor and Study Obs Gynae, Lady Harding Medical College, a Fellow of the Indian College of Obs and Gynae, has held many organizational posts, made huge lists, secretary, editor, treasurer, AOTGB, NACHI, North Zone Coordinator, Foxy Infertility Committee, Quiz Committee, and we know that she has been doing a great job on all these. She is presently chairperson Quality Improvement Committee, and I worked with her, and it's actually quality improvement in that committee. Member National Mentoring Group for Medical Colleges, member expert group on maternal nutrition, National Facilitator for Adolescent Health, more than 100 publications, and 3 books. Dr. Anita Sabharwal, we all know her as the dynamic secretary of TOG SD, and she does great meetings. She's chairperson of Adolescent Health Committee, AOGD, executive member of AOGD, at present chairperson Public Awareness Committee of ISCCP. Practicing gynecologist in South Delhi, has received the President's Appreciation Award, Foxy. Jyoti Agarwal, we go back a long way. We were together, I think, when we were very young. And she is presently Senior Consultant and Director, Life Care Center at Life Care IVF. She is the President of Delhi Gynae Forum East and a certified trainer for infertility and IVF. Dr. Bindu Bajaj, again, we go back a long way, worked together. She's a senior specialist and associate professor in Substem Hospital, and she is spearheading the team for the IVF center. She has a PG certificate course in hospital management and is a reviewer of articles in research journals. Field of interest is infertility and laparoscopy. Shweta Mittal, a dear friend, we all know her. She is a senior consultant at Gangaram in the IVF unit, editor Indian Fertility Society, treasurer AOGD this year, recipient of many awards, and a peer reviewer of many journals, and an excellent academician. It is really great interacting with her on the academic forum. Dr. Dipti Nath, she's Director, Mother and Child Center, Senior Visiting Consultant at the Max Hospital, Parpaganj and Vaishali, and Secretary of the Delhi Gynae Forum. Has got numerous awards like the APJ Abdul Kalam Award to her credit. So, without wasting any more time, I will go on to the panel. So, I'm not going to waste time on Dr. Kuldeep. He's taken a very good lecture. So, let's go on to the cases. Dr. Manju, this case is for you, and Shweta, if you have any comments and the questions which follow. Mrs. A, 31-year-old, married for 6 years, trying to conceive for 3.5 years. Semen analysis is normal. TSH prolactin normal. Normal.
Dr. Surveen, you need to share your slides. I can't see.
You can't see?
No. Are everyone able to see?
No. She needs to share the screen actually.
One sec.
We can't see the slide.
One sec. Hello, can you hear me?
Yes, we can hear
Yeah,
you. We can't see your slides.
But I am not on the webinar as such. I don't know. I'll have to rejoin. Just a minute. Okay, you can see me now?
Yeah.
No, we can see you, but not your screen.
We can see you, we can hear you, but we can't see the slides.
You can unshare and share again.
Session, can someone help her?
Why is the thing just going into launching? I don't know.
Can you share rejoin? Can you share again?
Can you please share again? My thing is not showing the meeting anywhere.
No, we can hear you, we can see you, but your slides are not seen.
Okay. Can you see them?
Yeah, now we can see them. Yeah,
There
you can
are.
just.
Yes, absolutely.
So I'm not going on to the details which Dr. Kuldeep has already covered. So this is case 1, Mrs. A, 31-year-old, married for 6 years, trying to conceive 3.5 years, semen analysis normal, thyroid prolactin normal, normal patent tubes, AMH normal. She has undergone 3 cycles of ovulation induction with clomiphene. Follicle has formed, endometrium is excellent, trilaminar. The question is for Dr. Manju, with Shweta taking the questions from the audience and if she has any comments. Factors to be considered in decision making in this particular patient.
Surveen, what were her cycles like? Was she anovulatory or did she have ovulatory cycles?
They were regular cycles.
They were regular cycles. So that means this is the case of unexplained infertility.
Yes.
Right. So the patient is 31 years of age. So
Yes.
the age is not on the wrong side from that point of view.
Yeah.
She's been trying for 3.5 years.
Yes.
So, well, that is okay. I'm to say it is again borderline. So not a very prolonged history of infertility, but well, 3.5 years for 31 would be okay. We need to be kind of proactive in this case.
Yeah.
And then I would like to have her ovarian reserve. I think you've not given us anything.
No, I did give 3.5 is her AMH.
Right. Yeah, the AMH is okay. So her ovarian reserve seems to be fine, right? So I think this is a case which seems to be suitable for controlled ovarian stimulation and IUI. So that is what I would plan for this patient. And
so this patient has come to you on day 10. And the ultrasound is showing a dominant follicle, and we often get patients like this, and she wants the IUI in the same cycle, maybe as a natural follicle. She says, doctor, just do the IUI, the follicle is there. If you're saying it is there, please do the IUI, because next cycle she's going out of station. For the next 2 cycles she's not there. Basically IUI with a natural cycle and unexplained infertility, what would your advice be?
Well, my advice in this case would be that it's not going to be of any use until unless on examination I found that she's got a bad cervix as well. So it is pure and simple case of unexplained infertility, then definitely not. I would suggest that she can go in for a controlled ovarian stimulation the next cycle and go in for IUI with that.
Yeah.
So I don't think so there is any point doing a IUI in a natural cycle in a patient of unexplained infertility.
Absolutely. So ASR in 2020 has also said the same thing, that natural cycle IUI is of no use compared to an expectant management.
It is an unnecessary intervention, so I would suggest against it. Yeah.
So then she goes on to saying, okay, next month I'm not going to be with you and I'm going to be out for 40 days. So can you give me clomiphene and I'll try naturally in the next cycle when she's out of station?
So one thing is, she's already had 3 cycles unnecessary, which were not required if she was an ovulating person. So my advice would be definitely against it.
And if it was her first cycle, what?
Still no. So I would not give any kind of ovulation induction alone.
Yes.
A patient who is already ovulating, definitely not.
Is there any other medicine you can give me? Was a question whether you could give her some other tablet rather than clomiphene.
No kind of ovulation inducing drug would be to her until unless I couple it up with IUI. So alone, I would not be happy giving thing. Yeah.
Letrozole does not count. It's as good as clomiphene as far as giving it without IUI. So she also asked you that if you're saying it's not of any use, can I increase the dose and then maybe it will be of any use? Is that possible? Letrozole maybe?
This intervention does not have any role to play. So this intervention, and people actually come with ovulation induction drugs in unexplained infertility, which I would not support.
So increasing dose has no role in it, and we just go for clomiphene induction IUI. That is what you are saying, right?
Yes.
And that is what the recommendation is. They found that from 9% you go on to 31% for conception, although multiple gestation may be there. Would you prefer letrozole and IUI in unexplained infertility vis-a-vis clomiphene and IUI?
Now this is a little tricky.
Unexplained infertility we are talking about.
This is a little tricky in the sense that we always say letrozole is a better ovulation inducing drug because it is monofollicular development, and here we are aiming at 2 or 3 follicles. Yeah. So with 2.5 milligram, I don't know, but there have been reports with 5 milligram of letrozole, and people have used it. And if you go to the latest evidence, they say that the results with clomiphene with letrozole and gonadotropin all are equal, so they are almost comparable. But in my own practice, I am much more comfortable with gonadotropins because with clomiphene you always have that issue of anti-estrogenic effect. With letrozole you have that effect of concern of monofollicular development. But meta-analysis is showing different. They say everything is comparable. So either it should be a combination of letrozole with gonadotropins, like Dr. Kuldeep had shown in his data. So, but I have no experience of that. I would normally put them on low dose gonadotropins and do IUI.
And what would your take be on how many follicles would you aim for in an unexplained infertility?
2 to 3. I am happy with 2 also, but 2 to 3, not more than that. Definitely not.
What are the other parameters on ultrasound which you would look at definitely before you do the IUI?
I would be concerned about the endometrium. The size of the follicle, yes, that is what we would look at. So give a trigger at about say 18 mm or so, and then look at the endometrium. I would also be concerned whether the endometrium is not started changing. So because there are 2 follicles, so more estrogen, there could be premature luteinization as well. So I would be concerned about that part also.
And what would
I don't do any blood flow and other studies. I don't do. I look at the pattern and I look at the that's what, and the thickness. These are 2 things.
For IUI, I think that's sufficient. But if you have a thin endometrium, do you go ahead with the IUI?
It all depends. I would counsel the patient unless it is too thin, actually. So thin.
Where would you kind of stop?
I am happy with 7 millimeter. And if anything more than 7 or more, I'll be doing it. So it is the patient is counseled, and we take a call accordingly. Yeah. And the evaluation in next cycle, I need to look up in case I'm using gonadotropins, why is the endometrium not growing? I would be concerned about that. And I like to do a spontaneous cycle monitoring for all my patients before I take them up for any kind of ovulation induction. I would like to know what is actually happening in their normal cycles.
I think that's a very good practice, which many of us don't do, but that tells us so much about what has happened in the last 2 years of our life and how we should go about it.
No, we've done a lot of theses on this, and lots of changes you find out, and you find out, in 40 to 50% of the patients, you would find out subtle changes, which do get corrected when you add on ovulation induction drugs to them.
Yeah. So, which ovulation trigger would you aim at, and why?
I think I would go in for HCG only, and I would normally give 5,000 international units. That's what I normally give in my practice.
Is there any time that you give 10,000 also, or is it 5,000 as a?
I normally give 5,000 only, so that's how I would go about.
So after the HCG trigger, when do you call her? What is your timing of IUI?
That's the same, anything between 32 to 38 hours. So normally, anytime between this, we would call them 34 to 30.
So that is what we are all following. But when I went into the ASRM guidelines of 2020, I actually found that they've written 0 to 36 hours of notices. And that surprised me because they said even on the day of HCG, you can do IUI. I have written here personal experience and comments because I do not have any personal experience on anybody who wants to comment on this can unmute and comment. Shweta?
I personally feel that doing IUI a bit later is better because post ovulation, the egg would be nicely sitting in the tube. And there are data suggesting that if you slightly delay your IUI, then it may have a better pregnancy rate. So I don't think that any one of us are doing IUI anything earlier than 34 hours in our practice. Unless, yes, a urine LH is so strongly positive that I'm expecting ovulation in 24 hours, but that's also ovulation.
So that's the only logic that she may have already started her surge before you gave the HCG and she conceives in that. But otherwise, I don't know, I found this to be surprising.
Because the post-wash sperms are capacitated sperms and they will lose their capacity to fertilize very soon. So doing very early IUI to me does not seem very appropriate.
I personally feel that the OVA should be available when we are doing IUI.
Yes.
Going ahead. So whichever way we can do it, I think that will be the best way. Yeah. Rather than waiting for the OVA, it should be the OVA waiting for the sperms here.
Yeah. Dr. Jain, any comment from you?
I'd just like to say that even if you delay a little more than 34 hours, like 36, after 36 hours, 38 hours, because you are giving full time, even if it is early ovulation, then also it will be helping you out. And if it is little delayed ovulation, so you can cover that. So there are reports that if you are doing it at 36 plus hours, you may get a better, of course they are not very robust data, but certainly there is a slight change in the pregnancy rate. So I think it should be done 36 plus hours.
Yeah, even I am doing it at 36 plus. So she comes for an IUI and the follicle is not ruptured. I think people have really asked this question. So why didn't you answer it once more? Are you going to do the IUI? And if you are you going to do a double IUI? What is your take on this?
No, actually, I do not do double IUI, and we actually do not in our practice, it is not always that we would see whether the follicle is ruptured or not. So it is not a routine practice, but we would do one IUI and then ask her to have normal contact. That is what we would do. Yeah.
Shweta, are you different with anything?
No, I think I'm absolutely in sync with the same answer because the concept is that once you give HCG, the LH surge has happened and the internal luteinization has happened and the egg has gone through the maturity. So by repeating the second dose of HCG, you are not doing anything further. They could be late ovulators. So having intercourse, I think, is something which we must promote the couples. Even if the IUI sperms are not, fertilizing, the natural sperms sperms have a longer longevity and they will make it. So by repeating an IUI or repeating HCG does not make a sense.
Yeah. How many ovulation induction IUI cycles would you propose?
I think Dr. Kuldeep has already given a good overview on that. So 3, max 4. Normally 3, I would stop at 3. If the patient insists, then 4th, not otherwise. Yeah.
So we've done IUI twice with clomiphene and the follicle ruptured and endometrial thickness was also very good. What would be your next step?
I actually do not give clomiphene, but you can switch over to gonadotropin in case you want here. But then
you combine it only gonadotrophins, or you're actually using them as first line?
No, I'm using it first line. I would like to review the patient profile once again. And in case I feel the patient profile is borderline, then I might even counsel her for IVF at this stage.
Okay.
Or else switch over to gonadotropin, offer her 2 more cycles of gonadotropin, and then she moves on to IVF.
So I had gone through the literature, and ASRM 2020 is saying that you just do 3 cycles of clomiphene induction and then go on to other treatments. They are with a low dose gonadotropin, which we use. But with a conventional dose, that means a high dose gonadotropin, the results are much better, but multiple pregnancy rate is also better. So the choice is either, giving a conventional right in the beginning and continuing with that, or probably going on to a higher dose and getting a better success rate at the cost of having a multiple pregnancy. I think this needs counseling and, individualization of the patient before you can take a decision. When would you take her for IVF? After ovulation induction IUI failures, oral failures, or as first line? So what is the take on this?
So I think we've already answered this aspect of it, that in case the patient has already had 3 or more cycles, then definitely she should go in for IVF straight away. There is no point. And then, of course, when we decided on IUI, so all the factors which helped us decide that she goes for IUI, if none of them, if any one of them is not there, say the age is more, the duration of infertility is more, right? So in all those cases, we can definitely, reserve is borderline. So we can always ask for IVF right in the beginning rather than delaying, her chances of becoming pregnant.
And in IVF, is it IVF or ICSI?
I think Shweta can give you a better answer to this. But you have a debate there. And if you go through the literature, they say it's equivalent. But I'm sure Shweta can throw some light on that.
So in our lab, we normally practice that if we have good number of oocytes, say about 15, then we do half and half. And if they show the similar fertilization in IVF and ICSI arm, we use the embryos which were made in IVF because they have a better implantation vis-a-vis over ICSI. But if we have only limited number of eggs, then it's a tough decision. Then we also base it on a post-wash sperm count and yield. And yes, it's not all ICSI for all cases of unexplained in my lab.
Yeah. So in our lab, it is usually an IVF because we feel that it's a natural selection of the sperm and that's why the implantation rate is higher. ICSI if it is indicated for male. Otherwise, we are doing predominantly IVF. What if she was older? This is the last question. That if she was 41 years, would you have changed your line of treatment?
I would have rather counseled her for a donor oocyte at this stage, in addition to going to IVF. Yeah?
If she had oocytes and she was older.
Yeah. No, I think I would send her for IVF, definitely.
Yeah.
Not definitely not. Yeah.
It's an IVF. Thank you so much, Dr. Manju.
Thank you. Yeah.
We come on to the case 2, Dr. Anita.
Yeah.
And Dipti, in case you have any comments or do we take the questions just now, Shweta? Do you have any questions?
So there were none of the questions which I could see from the participants, and I think we very much discussed everything in complete when it came to unexplained.
Session only.
Yeah.
Okay. So, Dr. Anita, 26-year-old, married for 5 years, trying to conceive 2 years with a normal hormonal profile. AMH is also normal. Semen is normal, but husband has difficulty in ejaculating occasionally. especially during when he's asked to do a timed ejaculation. She complained of severe dysmenorrhea 2 months back when a laparoscopy was done. A few endometriotic implants in the POD were biopsied and cultivated. Tubes were found to be absolutely normal and patent. The histopathology showed endometriosis. This patient came to you and she actually asked for an IUI. My question is that with endometriosis, are the results of IUI different, or would you counsel her and tell her that you are as good as anybody else?
Right, as Dr. Kuldeep Jain has also already mentioned in his lecture that only it's not of any use, the IUI in case of grade 3 and grade 4 endometriosis. But in the mild form or the minimal endometriosis, IUI is definitely useful, but definitely the pregnancy rate is decreased by 30% in these
And that is
cases.
probably because of all the things which are released from the endometriotic implants
Yeah,
which are toxic to the.
yeah. So the endometrial receptivity as well as the implantation failure is there because of those toxins. Yeah.
So husband had a problem with ejaculation, so he said, "I'll get a home sample." What are the
Okay.
instructions for semen collection to be given, and any medical legal aspects in this?
Yeah, firstly, they should abstain at least before bringing the sample for analysis. He should abstain at least for minimum 2 days. And then he must wash his hands and penis with warm water. And then he should rinse and dry with a clean towel and must pass urine before ejaculating. And he should use a sterile container so that there's no contamination, and that should be labeled only along with the wife's name and the exact date and time of collection. And the contamination should be avoided because he should open the cover only while putting the semen inside. And he should use only masturbation. He shouldn't use any other method for producing semen, and no use of soap, gel, lotion, because they are all toxins and they'll be toxic to the sperm. Even lubrication, even saliva, they are all toxic. And then he should ejaculate directly into the container to avoid contamination. And it should be, the entire ejaculate should be collected. In case by mistake he spills some, he must mention there which part, whether the initial part or the later part or the middle part was lost. He should mention, and then he should put it in a biohazard bag and seal it, and then he must keep it near the body because he can keep it in some pocket or somewhere so that the temperature is maintained. No artificial means of temperature maintenance should be there, and he should keep it upright and then bring it as soon as possible, especially within 45 minutes. It's better if he should reach the lab, and they should already be intimated about it so that there is no delay in processing.
Immediately prepare the.
And also medical legally, because since he is bringing from home, and certain patients who are azoospermic, they don't reveal it to their wives, so he must give an undertaking or declaration that the sample was brought from home, and so that the hospital is not responsible later for any problem which arises for regarding the source of the sample. So this is what it should be done.
So semen was prepared, was received and prepared. Doctor was busy in the OT, came after 45 minutes. What could be the impact? Can this delay have on the success rate? What is the ideal time for semen collection to preparation and semen collection to IUI?
Yeah, ideally, as we know, like if he brings, now in this case, he's brought it more than 30 minutes, means 45 minutes. So ideally within 30 minutes, it should be processed, and otherwise the success rate decreases. So this was the processing. And now from home, if he is brought within 90 minutes, it's very, very good, because the whole process, ultimately, because the whole process should not take more than 2 hours. So bringing the sample and then processing, both are very important.
Is Dr. Manju there? I think she's left. She had another meeting at 5:30. Okay. What is normal semen count?
Normal semen count, minimum we say is 15 million per ml, the sperm concentration, and the ejaculate should be minimum 39 million per ejaculate. That is the count, and the volume should be minimum 1.5. It may go on up to 7.6, and we have to see the motility. The progressive motility must be minimum 32%, and the total motility could be 40% minimum. This is all minimum. And the live sperms, they should be minimum 58%, and the minimum normal morphology should be 4. It's a range 4 to 48, but it should be there. And the pH must be either 7.2 or more than that. And there shouldn't be, the leukocyte shouldn't be there. There should be less than 1 per million per ml. That's about the normal parameters.
What are the two main techniques of semen preparation used, which we are doing practically, and what is the principle behind them, and how do you select the technique?
Basically, there are two main techniques which we use. One is the swim up method, and the other one is density gradient. Swim up method is basically for those samples which are mainly normal. They have normal parameters, normal motility. So in that case, the semen is layered after centrifugation with the medium, and the good motile sperms, they swim up, and these sperms are taken for the insemination. So here the sperms are selected on the basis of their motility and also the capability to swim out of the seminal plasma onto the layer of the medium from where they can be picked up. And as I just mentioned, that if it's basically used in those cases where the parameters are all normal, they have good motility. Only thing is they may have some more debris in it. That is the only side effect.
Not that.
Yeah. And the density gradient is basically for those samples which are not of good quality, they're suboptimal. And so in that case, they're layered in different gradients of 48%, 80%, so that the dead sperm and debris are, according to their density collected in these. And the motile sperms, they stay behind in the bottom as a separate pellet. And so that can be taken. So as I mentioned, this is because of the suboptimal sample, we can use this. And this is very efficient, and a very clean sample is, we get it with this kind of method. So it can be used for those suboptimal samples.
Thank you, Dr. Neeta. That was very concise.
Thank you.
The third case is for Bindu, and Dr. Manju, I think, is not there. So Shweta, would you add on?
Yeah, sure. Yeah, sure.
So Mrs. X, 32 years old, married for 2 years, trying to conceive 2 years. She is a known PCOS. TVS is showing PCOS with a normal uterus. Thyroid, prolactin are normal. Semen is normal. Clomipene induction 3 times. Ovulated, but no conception. She came to you, you offered an IUI, and she opted for the IUI. Patient position for IUI, catheter not going in, uterus was acutely anteverted. How would you troubleshoot in an IUI where you're having a problem?
So rather than being confronted with such a scenario, I think I'm supposed to anticipate it, because while the follicular monitoring is being done, one is supposed to see the axis, the uterocervical axis that is there. So many times while monitoring, one sees the length of the cervix, one sees the length of the uterus, the cervical uterine angle, and in case that has been missed and one is confronted with such a situation, there are 2-3 options that we have to start with. Ideally, the patient should be told that she should not pass urine when she is coming for IUI. The bladder should not be completely full, but at least 2 to 3 hours of she should have been passed urine 2 to 3 hours back. So that would antevert the uterus on its own. So in an acutely anteverted uterus where she has passed urine and now the bladder is empty, we try to, rather than normally one is doing IUI with Cusco speculum, using Cusco speculum. Now what the option is, either one can use, instead of Cusco speculum, one uses the SIM speculum with anterior vaginal wall retractor. And I routinely use the AV retractor for such patients and try to slightly retract the anterior vaginal wall. This itself straightens sometimes. If it doesn't, then the option is to take a valsellum or tenaculum and hold the anterior lip of the cervix, and gently do it. In case it doesn't help, then the option is to do ultrasound guided IUI. And there are catheters which have an embryo transfer catheter, which is slightly, because the IUI catheter is very, very sometimes soft and one is not able to manipulate the angle. Then one can change the catheter, use a little firmer one, or one with a stillet, so that one can go in a particular direction, so that it takes the shape of the passage. And last option is using sound. I have used it once in a while. I use the thinnest possible sound and then try to railroad the method. Simultaneously put the IUI catheter from behind while the manipulating with the uterine sound, and withdraw the sound and put the catheter, the IUI catheter, while withdrawing the sound. That also helps sometimes. So these are the various options that are available, but one should be very gentle. It's very important the patient should not be made to relax, because anxious patients also make IUI difficult. So proper counseling before doing IUI is very important.
And I think the last resort would be just doing a cervical.
That last will be, mostly there is some element of cervical fibrosis also in such patients. Not only acutely, and diverted uterus can be easily maneuvered by using these methods. But in case one is not able to go past, that is mostly because of having some kind of cervical stenosis, which then has to be, one does only intracervical insemination in such patients and bring her back to the OT during her periods and try to dilate the cervix a little for such patients who are having repeatedly such problems.
Have you ever done a hysteroscopic guided dilatation in these kind of patients?
Routinely, no. I would just
do it when our ET catheter doesn't go in, then we do it for IVF. But IUI, I've never done it.
Any patient who has had trouble while doing IUI, I have called her in during her periods, and I have done an OT. I have slightly dilated the cervix, and next time the catheter has gone without any difficulty.
I just want to add one more thing that recently, I have an IUI catheter, which is like an embryo transfer catheter with Stimulate, because this costs only 300 rupees. It is only available by one vendor, and that is what I use when there is a difficult IUI. So, because not everyone will have the option of keeping an embryo transfer catheters, and which cost about 3,000 rupees.
Yeah. So this is made like the embryo transfer. It's like the coop.
So it has an outer sheath through which a Stimulate goes, and later on you can put a loaded inner sheath with semen in it once the outer sheath is negotiated.
And it's thinner than the rest?
It's absolutely like an IUI cannula, with the outer sheath is plastic, inner is a Stimulate, and then there is an inner catheter on which you load the semen, which is exactly like the inner of the embryo transfer, very thin.
So after IUI, what is your take on bed rest and luteal support?
I do tell my patients to rest for 10 to 15 minutes. It makes them comfortable, and it's been shown to be actually anxiety is relieved of the patient, and she kind of, I tell her to have positive thoughts after IUI so that she conceives in that cycle. And about luteal support, sir just told us, Dr. Kuldeep Jain just told us that it is luteal support is being, as a norm we are giving, but naturally for oral ovulations like clomiphene, luteal support is not, at least the literature doesn't say that one needs luteal support. And if you are using gonadotrophins, of course luteal support has to be given. And there are a lot of options for giving luteal support. We have many drugs, right from micronized progesterone and dydrogesterone, and micronized progesterone is available in various forms, be it vaginal gel or using it as soft tules. Micronized progesterone soft tules are available, and micronized progesterone orally doesn't really I have seen many patients who have come with side effects with oral micronized progesterone, and they are not even effective. 90% of it gets metabolized by the first bypass hepatic metabolism. So it's important that and especially the metabolites that are released after that, they give rise to, they centrally act and they give rise to a lot of dizziness, and patients come with a lot of sleepiness. But some of the patients are quite comfortable, but the micronized progesterone oral preparations, whereas intravaginal preparations are much more useful as luteal support. So around 400 milligram of micronized progesterone intravaginal, 200 milligram morning and evening, I am writing for patients after IUI at the time of IUI for another 14 days before we test it for pregnancy. Oral dydrogesterone 10 milligram tablets morning evening is also reasonably good for luteal support.
So which do you prefer, the micronized or the dydrogesterone?
Actually, micronized progesterone is available in the hospital. So preference, and anyway, dydrogesterone is reasonably expensive also. For our patients, I will prefer micronized progesterone.
Shweta, anything on that?
So higher the stimulation, more is the luteal phase required, and lower the stimulation, they don't need a luteal phase. I mean, theoretically, practically, yes. If I am asked, I actually land up giving luteal phase support to all my IUI patients, and
No,
which is
what
just a
is
vaginal micronized progesterone, 200 milligram twice daily.
okay. Okay, we go on to case 4. The case is for Shweta and with Jyoti alongside. Women 30, this is a woman who's 30 years, married for 3 years, trying to conceive right from the beginning of her marriage. Hormonal profile is normal, AF is 2.9, tubes are patent. Now, the semen, the count is 10 million, 50% motile, 15% actively motile, 5% normal morphology, and pus cells are written, or round cells are written as 3 to the power or 10 to the power of 6. What next? Any other test which you would like to do? Anything?
So if we see the cutoff of the pus cells, which is way high, so it is 1 million, 1 into 10 raised to the power 6, which is 1 million. Here it is evidently 3 million. Now, unless we do a leukocyte esterase test, we will not be able to find out whether they are immature cells, they are epithelial cells, or they are actual pus cells. So we need that. It's a staining test, and we see the brown cells. And if you see, so if this patient actually has 3 million and there is no faulty collection, we have to get into the detail. Number one, we need to know the symptoms. Has he been having recurrent balanitis, urethral discharges, any sexually transmitted diseases? We will have to rule out prostatitis. We will have to do a semen culture and a transrectal ultrasound in these patients. I think this is one aspect what we are looking at, that is the infection part. Now, if this patient had not had infection and we are not looking into that and we are only looking into the counts, then we will label him as a oligo and asthenosospermic male, and then our whole investigation from that point of view starts. So if we only leave aside the infection part, then we get into all the other causes of oligoastheno. So we can start thinking of varicocele, we can start thinking of genetic causes, idiopathic, any drug-induced, environmental, any recent viral fevers, any recent. So and then the whole hormonal profile will start coming into it. So I think this armamentarium will, in this particular case, possibly will happen from 2 angles, if I am, taking it from that point.
What about semen culture?
What about?
Semen culture.
Yes, so semen culture has to be done very properly in a standard lab. He will have to clean the penile area with soap and water. He will open the culture bottle only before ejaculation. He will not, lift the lid upside down. He will collect it in a sterile manner and give it in a standard lab. It is very, very important because most commonly the labs report skin contaminations. But if it's a true pyospermia, we need to pick, because these infections are very difficult to treat. A simple norfloxacin or ofloxacin may not work, and they will need extended treatment for weeks together. And sometimes people have to even do a prostatic massage and take urethral, cultures.
So now my next question, you mentioned varicocele, you mentioned prostatitis. Are you going to refer to a urologist or not?
Yes, I think I will refer this patient because they need a proper clinical examination and we need to come to the diagnosis. As a gynecologist, I don't think we should give antibiotics at our level, but in conjunction with an andrologist, yes, we should do it.
So this was a very interesting study, 2018, where 9,000 men were evaluated and 17% who had a male factor went through ART procedures without being, even IVF without being evaluated by a urologist. So I think the take home here is you have to send to the urologist, as you said. So in the treatment aspect, would you give antibiotics?
So if there is a true pyospermia, and if there is a culture positive, then as per the culture report, yes, they will need treatment. I can give you one example, very interesting. Many years back, one patient was undergoing IVF, had a culture, a growth in the dish. This was many years back. This man had come from Bahrain. I remember that he Every time a semen culture was done, a new organism grew. For 8 months, right up to meropenem, he was given antibiotics, but his pyospermia never became okay. This was one case, and he never conceived also, despite everything. So sometimes genital tract infections in men can be very, very notorious. But also do not keep giving quinolones for months together, because they start reducing the count and motility big time. So we have to be very cautious in that too.
What about antioxidants?
So yes, I think this is the case where you will give antioxidants, because genital tract infections and oxidative stress go hand in hand. So, I mean, I would say that antioxidants for genital tract infections, for patients on radio chemotherapy, for patients who are known chronic smokers or alcoholics, and drug abuse. For them, yes, we must give antioxidants. In the rest of the cases, or varicoceles, yes. The rest of the cases, I have reservations and I don't give.
You don't give a routine antioxidant?
No, I don't. It's just because it's oligoastheno, I don't give antioxidants. I don't give.
Jyoti, any take on that? Do you?
Yes, I do give them antioxidants, especially vitamin C and vitamin E, especially in the COVID area. Everybody is advised to take vitamin C and vitamin E. I do believe in ROS. Even if the infection is not there, some kind of stress, definitely the ROS component is high. We don't have measures, measure them exactly, but there's no harm in giving it. CoQ10 and lycopene and carnitine.
So there are two views.
Healthy with lots of fruits and veggies.
So there are two views. One is that there is no harm. Second is that there should be evidence, and then I will give.
Yeah.
I think both are justified. Both are justified.
So what's important is that people have this concept that if we give antioxidants, the count and motility will increase. No, they are only improving the powerhouse, but they will not evidently increase the count under microscope. This is what I just wanted to say.
Definitely, that is true.
Yeah.
But many men ask for treatment, they'll say, no, give us. Okay, what about clomiphene?
So, I have come to a conclusion that clomiphene for men, I'm giving it in two cases. One, who have a slightly high FSH, a slightly low testosterone, and with some kind of an oligoastheno, or even before testicular sperm aspiration, not related to this case. Basically, my aim is that I want to increase the intratesticular testosterone. However, giving clomiphene left, right, center will not improve. And eventually, we have to take a decision for male infertility when to refer them for IVF ICSI. It's very important. Don't go on giving them prolonged, unnecessary medical treatments and empirical treatments.
Yeah, it goes on endlessly and nothing happens for months and months.
Yes.
And they come to the IVF. So this is, I put the count here again, and I would like to know what you're going to do with this patient. And
okay.
What these terms mean. We look at them and not...
So see, WHO gives 15 million per ml as the cutoff for being a normal count. Now, we have to be very clear that the one in the black, what people are seeing are the pre-wash counts. So we are looking at mild, oligo, and asthenosospermia is quite a lot because only 15% are active. So 10 to 15 is mild, 5 to 10 is moderate, less than 5 million would be severe. So this male, let's forget about the pus cells. Here we have treated him, let's suppose. So they are the ones who can be subjected to IUI. So what has been suggested, which we also practically don't do, that if we can do a post-wash count in these patients before even subjecting them to IUI and stimulating the female partner, we can have a good idea that if the most post-wash motile sperm count is more than 10 million, they saw the per cycle pregnancy rate was about 16%. So less than 5 million motile sperm count, they hardly ever saw any pregnancy. Between 5 to 10, you are expecting about 13% pregnancy, and 10 and above, you're looking at about 16% pregnancy rate. So this patient can be offered an IUI cycle.
So here I want to know what in your practice, what your cutoff is. When you tell the patient, sorry, मैं IUI नहीं करूँगी.
I think if it is overtly 5 million and less, and I don't think I'm going to give them, because I have seen my data. The pregnancy rate is not even 5%.
You're right. So what about the semen preparation technique here? Which one are you going to use?
Okay, so in this case, if there are pus cells, or as a universal, if I have to adopt one process, it will be double density gradient, because I'm removing the plasma cells, I'm removing the leukocytes, so I'm removing the reactive oxygen species and the dead sperms. So if I'm asked to choose one, I would choose double density.
Okay, so semen was prepared and this is what they got. A total progressive fertile insemination count of 1.5. I think you've already answered this.
So, in this particular case, okay, I will go ahead with IUI, but I will ask the couple to have a natural contact also that day. I will ask them, because sometimes that also may work. Because we are not giving up on a cycle, we are not throwing the sample, but we are also prognosticating them that the pregnancy rates are very low.
So, I usually keep like till 1 million, I tell them that it's very low, but I go ahead if you want to.
Yeah.
So I can inform consent from them. But Jyoti, what about you? Is there a of where you can?
As Dr. Shweta said, I'll do an IUI and ask them to have intercourse also. If it doesn't work, then we'll see it in the next cycle.
Yeah. So, like you said, Shweta, 10 is very good, 5 is also, more than 5 is okay, but less than 10 is totally not okay. On the day of IUI, follicle has not ruptured. Would you do IUI?
So I absolutely go ahead with IUI, because if I've timed the procedure, I will do it. I will also counsel them that they could be late ovulators, and that is why for me, the couple to have a natural contact is also very important. So if they can manage the same day, it will be good for them.
Would you consider double IUI in this session?
So out of all the indications of IUI, if I say anovulatory, unexplained, unilateral tubal defect, mild endometriosis, and male, if literature supports a double IUI, then it's for male factor. So in this case, yes, we could have planned one at 24 hours and one we could have planned on the day of ovulation.
Yeah, in fact, with an odd 4.6 is the strength of this study. And what they say is that it definitely, for the second indication where they say a double IUI may be useful is, like you say, late ovulators, or they have multiple follicles and one may have ruptured and the others may still be there. So to approach those double methods. And also the reason for this is, they said it is actually increasing the total motile count which is required. And the lifespan of a sperm is much less in a male factor infertility. So they say that maybe a double may help you. So next one, after 2 months, he does one IUI, goes away, comes back after 2 months, and this is his count. 2 million, motility 10%, actively motile 5, morphology 2, total motile 4.1. What will you do? Any other investigation which you would?
Okay, okay, to be very simple, I'm going to really start priming them, and I'm sure I would have done that in the previous 2 cycles, that start thinking of IVF. And then you can get into all the jargon of finding the cause, whether you want genetic, endocrine, you want to look at varicocele. If he's convinced to go for an ART, then I think I'm going to just subject them to an IVF straight away. I don't want to waste time, because I know that male factors, there are hardly much which we can offer. Most of them eventually land up in IVF, and some fortunate ones one day get pregnant on their own when we give all the odds.
So actually, now when you analyze,
you can do that.
You're doing a DNA fragmentation, you're actually not doing anything, because you're going to do an ICSI in any case. So if the DNA
yes.
is high, in any case, the answer is ICSI. So it doesn't help. Okay, thanks, Shweta. That was good.
Thank you.
Case 5, Dr. Dipti and Dr. Neeta, please, questions and your take. 32-year-old, 10 years, thyroid prolactin is normal, regular cycles, PVS is normal, semen shows azoospermia. She does not want IVF. What are you going to suggest for her? Is Dr. Dipti there?
Am I audible now?
Yeah.
Patient is not keen for IVF. So the next option is insemination with donor sample. That will be the best choice we can
So,
offer.
patient says she wants to get her husband's brother as a donor. What will you tell her?
As far as the counseling part is concerned, if I go with a patient who has been declared as azoospermic, so there is a lot of psychological issue, a lot of emotional impact, and curiously, these things are not looked into our clinics. But they have to be told that there are a lot of legal issues vis-a-vis having a relative as a donor. An unknown donor would be a best choice where we have done thorough testing. We know that the HIV status, all the viral markers, diabetes, hypertension have been ruled out. And obviously, it will be better if the patient goes for a donor sample rather than a known sample.
Okay.
And besides looking into these, as far as the counseling is concerned, we are going to talk about the emotional impact. So a professional psychologist is involved in this. The legal issues have to be explained. I would go for the unknown donor sample rather than husband, brother.
Surveen,
Yeah, Dr. Jain.
yeah.
Please
I think here the message should go like known donor legally are not permitted. So
Yes,
we
legal
have to
issues.
follow. We have to. There is no option. They should be told very bluntly. Many times you may have lot of pressure from. It is a old patient of yours who has brought, and many times there is a lot of pressure from the parent side, from the in-law side. I think these patients, they should be told very clearly that it is not legal and it should not be done. So I think this message should go everyone very, very clearly.
Yes, I think we often get these requests.
Yes, yes.
Yes.
So, would your ovarian stimulation be different? Do you need ovarian stimulation?
So again, Dr. Kuldeep has already mentioned that we optimize our cycles, though the theory mentions that now in this particular case, since we've already documented that tubal patency and she is ovulating, so there is no female factor involved. It is only the azoospermia. So one, keeping in mind the young age and normal ovulation female partner, one can go in for natural cycles with urinary LH to detect the ovulation. So it is a physiological cycle. It is being done with the convenience at home. And once the LH is detected, then IUI is done only once. And then of course there are patients who would find that this remote treatment, when she is not in touch with her physician at all, she would like to come talk to her physician on an alternate day basis and would want a more scientific evidence of ovulation, may want to go in for ultrasound follicle with HCG as a trigger. So both the cases, the pregnancy rate and the live birth rates are almost comparable. It depends upon the patient's choice, the age of the patient, and the center also. Some centers may not be working on weekends. They may like to time their IUIs. And those centers who are working 7 days a week, it won't make a difference. However, the clinical pregnancy rates are same in both the cases, but you have to keep the age of the patient in mind.
So the other thing is the consent forms, because many gynecologists are doing IUIs in their chambers and they're not taking regular consents. It's very, very important, especially
Yes, we have got the ICMR guidelines are very clear. So you download the consent forms from the website and be very clear about the consent. I believe you have to have a consent first for a request for an IUI for donor sample, and following the request there is another form where you give a consent for doing the IUI, and the forms have to be kept in triplicate with the patient in your own file, and they have to be submitted also.
The legal issues, I put this up because we actually faced one in our department where the blood group was different from what the sample had come. So actually the doctor is not responsible for this because the sperm bank is giving you the sample. You can no way test the blood group of that sample. So if the sperm bank gives you a wrong sample, it's not that you are responsible. So we actually made our institute sign a contract with the sperm bank where they that they are responsible for all the parameters which they are sending us. Because that keeps us safe. Blood group is one thing which, a patient requests it should be similar, and supposing it comes out to be different, it's not your fault because the sample was wrongly labeled by the blood.
Yeah, but when we send for a requisition from the bank, don't we write the blood group also?
Yes, we write and they also write. So
Yes.
we may have asked for B positive and they may have written B positive, but it may actually be a and how would we know?
Yeah, true. True.
So that's why I put in those.
Yes, yes.
So what about intracervical insemination in a donor? Because there's no problem.
No, I would rather go for intrauterine rather than intracervical, because again the success rate is more in IUI reserve is the intracervical, and where already there is so much of stress, and otherwise also when you take cases of unexplained infertility or other cases where again the success rate is more, unless and until there is a problem with cannulation and your patient has not been very good, you're having some difficulty, you might end up converting it into an intracervical insemination.
Absolutely agree with you, because if you are putting on the table, you might as well just put the catheter inside the uterus rather than leaving it at the cervix. Both studies are not showing any advantage of cervical over intrauterine.
IUI cycles.
It's a well-tested method.
Yes.
Okay, thank you. Case 6, Dr. Jyoti and
Yes.
Anita, 24 years old, infertility for 3 years, semen is normal, TSH prolactin is normal, tubes are patent, her BMI is 18, she is a PCOS on ultrasound and she is anovulatory. We started 50 milligrams of clomiphene and what we got was this, 8 follicles, 15 to 18 mm, day 9 scan. What are you going to do?
See, she is a case of a thin PCOS and the picture on ultrasound clearly shows a hyperstimulated ovary. So she is going into OHSS. My first option will be to cancel the cycle.
Okay.
And not to do anything in that cycle.
Any other option?
If she insists, then we can convert into an IVF cycle with the counseling that the results are not very good. If we convert an IUI cycle into IVF, and in case she still persists with that, we need to give an agonist trigger, freeze all, and then subsequently, maybe after a month or so, we transfer in a fresh cycle and do a FET cycle rather than transferring in the same cycle. We need to freeze.
If you're converting to IVF, would you like to do some tests then and there?
We can we will see how many follicles are there and what is their size, and we can do a serum estrogen levels to see whether she is in OHSS or not.
So this patient serum estrogen was 3,000.
So she is in OHSS.
Yeah. So she says that she does not want to lose her chances and wants to go for a rescue IVF. How do you counsel her regarding these questions? What is the chance of my having a baby? What is the chance of hyperstimulation? What is the chance of multiple pregnancy? And does it ultimately cost more to me getting this baby?
Definitely, she has a chance of having multiple pregnancy, chances of hyperstimulation, and I need to do it with an antagonist and then give a agonist trigger and then freeze on.
So,
some OCP pills for next 2 cycles and then make her endometrium and then transfer.
So what they found was that the cost actually per baby falls less in this case because they have a better pregnancy rate than the conventional IVF. And hyperstimulation, if you freeze all, is not there. Multiple pregnancy, again, if you do a single embryo transfer, you counsel her on all these factors. And probably
single blastocyst transfer, that will reduce the chances of multiple pregnancy.
Dr. Jain, what is your take on this? What do you do with your patients when they come like this?
See, we do rescue IVF, but I am not having a very good experience, a good outcome with rescue IVF. We have done multiple rescue IVF, but usually I discourage them until unless, because a lot of counseling should go actually when you are doing rescue IVF. Okay. If they are not counseled, then usually you lose the patient in the next cycle. So that is very important. Best way is to cancel these patients. Don't do anything, just follow them. Uh, uh, but if the patient wants, yes, you can go for rescue IVF. But see, this report, what you are telling, that conventional IVF chances are less than rescue IVF. I don't agree with this report. Uh, my experience is conventional IVF because it is well controlled cycle. And when you are doing rescue IVF, you are compromising on so many things. So
Yes.
it cannot be theoretically also. So I really doubt.
So this paper which I read and I put there, it was a comparison, and it was 45 versus 32, and they said that this is because the quality of the egg is very good, as the estrogen level per egg is high, and that was their logic of,
Maybe theoretically it may be explained, but practically, what I see in my practice, it is always a poor outcome in rescue IVF. Yes, the
That's what
patient
I wanted. I wanted the practical experience.
Can I put one just observation of mine, that I've never seen this kind of a hyperstimulation in just a pure clomiphene cycle.
Yeah.
We'll hardly ever seen a 3000 picograms. I think it must be picogram, not picomole. E2 in a pure clomiphene cycle. I don't expect. Only cycles which I have converted to IVF were gonadotropin cycles, and then they are like any other IVF cycle, because even with the low dose of gonadotropin, if it could build up so much of estrogen, so those follicles actually were ready for IVF. But if the E2 levels are very low and you see multiple follicles, never convert them to IVF, because you will hardly ever get any oocytes.
Yeah.
So E2 levels are the most important determining factor.
Yes.
Levels with I have had 1 or 2 cases where I've seen 6 follicles with a clomiphene.
Yes.
Patient. That's why 18 BMI 50 also.
Yeah. So 6 follicles, I will not convert them to IVF. I would rather make 15 in gonadotropins and then do IVF for the same patient. Because out of 6, we may just get 4 eggs and it would be a poor cycle.
So our take on this would be unless we have a good amount of follicles and the gonadotropin cycle, we do not convert it and we leave it as it is and cancel it.
Moreover, we can definitely try with letrozole in the next cycle.
Yes. Dr. Sulveen, even I have seen one patient, very thin built lady. We gave her only 50 milligram of clomiphene. She was lost to follow-up, came with triplets, and she had multiple follicles. We had told her not to contact. We had completely cancelled the cycle, but she came back.
That happens. That is okay.
So for cancelling, what are your instructions, Jyoti?
We ask her not to do abstain, not to have any relationship, and to make it sure, I usually give them an injection of progesterone and 2 injections of antagonists to make sure that everything is cancelled, the way we do it for donor IVF cycles. And then she should come back when she has a period. Then we put her on Novolon maybe for 2 weeks and metformin before we take her up for next cycle, maybe for 2 to 3 months, so that she does not land up into OHSS again.
Thank you. So this is the last case. 29-year-old woman married for 1 year. Paper.
Yes.
Cycle, TSH normal, everything is normal. Prolactin normal, TVS normal, ovaries. Husband is HIV positive. Semen is normal. Wants conception. What is the advice, counseling, any other investigation required before the treatment?
Okay, so they are serodiscordant couple, and husband is positive. Theoretically, 2 methods have been advised, but what I practically advise is an IUI, because for me to advise having an unprotected intercourse around the time of ovulation is something which, I need to counsel a lot, because there is about a 4% conversion rate. So if you're talking of IUI, 2-3 aspects. Number 1, I don't want to subject them to multiple cycles of IUI. Number 2, I cannot say that there is a zero risk. It could be a negligible risk. I need to, I need to know the HIV status of the female partner. Be very sure that she is discordant. Next, you have to do is that we need to know the CD4 counts and the viral load. So we need to know the RNA, and we need to know whether he is on, antiretroviral therapy or no. He should have been on that for a couple of months. His CD4 counts ideally should be more than 400. That's what we take it in our center, but definitely more than 200. And viral load should be negligible. So less than 50 copies are negligible. That is the time when we can actually suggest them IUI, but also do all the other infectious markers. So hepatitis B, hepatitis C, VGRL. Please investigate the couple in toto. I would like to investigate the female partner also, because I want to be very sure that when I'm doing an IUI for such a couple, I am, completely ensuring that the female factor is not there. So we don't have two concomitant factors. Then very, very important that I need to inform my lab beforehand that such a discordant couple is coming, though every lab should understand that every sample can be affected, but they will be more cautious. You need to take a proper consent. Then your collection, your spillage, everything has to be. You cannot have 2 or 3 IUI sample preparations going on together in the lab. You will have to deal this case separately, then it has to be disinfected. But the very important aspect is that your lab should have SOPs for dealing with HIV positive semen samples and to prepare. So we do a double density method followed by a wash and followed by a swim up. This is what we do. Books, literature mentioned very good pregnancy rate, but our clinical experience is that pregnancy rates with such kind of extensive preparation is very low. It's very low. So is there anything else you want to add, Dr.?
Anything? So our lab is taking more than 350 CD counts, and viral load, actually we prefer it to be less than 50, but
and actually what you need to do, which we are not doing it in India, is after the semen preparation, we have to take a small allocate and do a RT-PCR on the semen sample. And we need to freeze the semen sample and only use it when the RT-PCR is negative. But none of the labs are, doing an RT-PCR on the prepared semen sample. So we only have to depend on the serum viral load.
Well, Dr. Cheta, aren't the recent guidelines and recent literature shows that if the woman is also on some kind of for limited period of time,
yeah, so they call it a PrEP, where they say that a small prophylaxis can be given around the time of IUI, but somehow the other I have not seen my medical people giving that.
Okay, because most of the literature now saying that this is the woman can take, the man is anyway taking.
Because there's a very large study of about 11,000 cases, and they did not see a transmission in a patient who was negative in the semen and was on HRT. And they said that good CD4 counts will bring good morphology of semen and better pregnancy rate. So this PrEP, I have really not been seen. I've not seen a female partner being given.
Okay, so there are some questions.
Yeah. Just to answer your IVF, the labs have to be geared. So we are not undertaking IVF for HIV discordant couples because we believe that the lab to do an IVF need to be really separate when they are dealing with HIV positive couples.
So do you use urinary LH kit for timing HCG, and what protocol?
Okay, so urinary HCG, evidence does not support. So they say that whether you in your IUI cycles you do an urine LH or you don't do. Number 2, whether you give an HCG trigger or you don't give, both of them have the same pregnancy rate, because maybe we are looking at a pregnancy rate of 15%. So in all the IUI cycles, we do not need to, because it has a false negative rate of about 30%. Unless, ultrasonologist is saying that there are certain signs of impending ovulation, then maybe you can make use of serum LH or urinary LH.
Why is luteal support not necessary in clomiphene stimulated IUI cycles?
Because the luteal phase defect incidence is low. Higher the stimulation, more are the estradiol level. More is the estradiol level, so more is the stromal glandular dyssynchrony. And that is why in gonadotropin cycles, they will need us luteal phase support. Vis-a-vis in clomiphene, if we are expecting a 10-12% pregnancy rate, they don't need it.
So there's one specific question for Dr. Shweta Mittal ma'am from Dr. Shweta Prasad. What brand of the IUI cannula she uses for difficult IUI?
Very so I will give you the number. It's a very cheap Indian brand. There's nothing robust about it. So generally all the IUI cannulas come within 100 rupees.
So Kriti, you can call up Shweta, whose number is Shweta. Can you please?
9910303056.
Because we don't want to endorse any brand out here.
Yeah.
Hydrogesterone and micronized progesterone, which is much better? Practical experience.
So we don't have data on IUIs and dydrogesterone, but we have data, very robust Lotus 1 and Lotus 2 trial in the fresh embryo transfer and luteal phase support, which is a non-inferiority study, and it says that dydrogesterone was equally good as compared to micronized progesterone. So yes, we need better studies and we can use it.
Okay, which antibiotic do you give for many days of pyospermia, Dr. Sana?
So that depends upon the culture report, whether you have E. coli, strepto, you have pseudomonas or whatever is coming, and then you will have to be in sync with either the nephrologist to actually decide on the antibiotic or an andrologist.
And the last question is Dr. Priyanka, failure to consummate marriage if patient wants IUI. Should IUI be planned with natural cycle or COH?
So, I can tell you the evidence. It says you can very well do natural cycle. And they said you can even do an intravaginal insemination in such cases. And then talking about my experience, that I have seen that most of the pregnancies happen with some kind of stimulation. So when you stimulate these patients, they kind of have better results.
There's one question from Avantika Sharma. What to do if FSH, LH, AMH is okay, but E2 is 23?
Yeah, so I don't get worried about it at all. I mean, I don't even monitor so much of hormone levels in IUI. You simply give them whatever drug you have decided as per the category of the patient and forget about these hormones. Make cycles easier.
Last question from Vaishali Jain. Any role of diagnostic lab or endoscopy in failed IUI?
Yes, so in diagnosing unexplained infertility, there is no longer the evidence which says that you need to do a laparoscopy to prove, unless there is an ultrasound suggesting posteriorly placed ovaries, stuck ovaries, endometriotic cyst, probe tenderness, or any history of PID or an abnormal HSG. Then I don't need to do a laparoscopy just to prove that they are unexplained infertility.
Dr. Jain, your take on this laparoscopy, hysteroscopy, when do you do it? If IUI has failed, will you do it or would you do it? You're mute.
I think I will take them up for IVF because fast track trial says that 3 years of infertility, 3 failed cycles, you can do fast track and go for IVF.
Yes, I agree. But if even in the first cycle or second cycle, if you are seeing something in the endometrial cavity, poor growth in spite of your good stimulation, and if you are seeing a persistent cyst somewhere in the adnexa, and patient wants to go for IUI, then it is better to plan a video hysterolaparoscopy before starting IUI. And certainly after 3 cycles of IUI, failed IUI, if you are suspecting something in the pelvis, then it is better to go directly for IVF. Regarding the hysteroscopy, certainly if there is any suspicion in the endometrial cavity during the stimulation, before taking up IVF, I will do the hysteroscopy.
Dr. Kuldeep, there's a question for you from Dr. Sana. Jain sir, how will we monitor and treat hyperstimulation in this PCOS patient?
See, for all patients, whether it is hyperstimulation or the normal, the TVS is the gold standard for monitoring. And with a good transvaginal sonography monitoring, you can prevent ovarian hyperstimulation because you can plan, suspect high-risk cases and start the stimulation with low dose. And once it go into the ovarian hyperstimulation, then of course the monitoring becomes by estrogen level and other things. So, but primary monitoring is always by TVS.
Okay, and one last question for Shweta. Does ICSI reduce viral transmission when doing IVF in HIV positive cases?
Yes, so in US, there is a lot of belief in doing ICSI for discordant couple. So definitely by doing ICSI, the chances of transmission would be very, very low as compared to IUI. But in IUI, we have a very large data suggesting that if your parameters are okay, then the transmission is negligible. But between IUI and ICSI, ICSI will have even further lower chance.
Yeah, Shweta, I also believe that if you have to do the procedure in a discordant couple, then ICSI should be a better choice than IUI. Use the transmission. Of course, the data is there that with less viral load you can go for IUI, but to be more sure, you should opt for the ICSI rather than IUI. That is my belief also.
I think we should offer the patient ICSI.
Yeah.
So I think we can conclude the meeting. All the questions are answered, and thank you. I had a wonderful group of panelists, all friends, and thank you so much for your input. Before we go, I just want that all of us wish Dr. Kuldeep Jain all the best for the North Zone Foxy elections. We have to be with him. We have to make our Delhi candidate win, and there is no way that he does not get our support. So please support him and make sure that all your friends, all your acquaintances vote. Because voting is important. Many of us don't vote.
Absolutely.
Thank you, Surveen.
Yes.
Thank you, everyone, for all your support.
Thank you so much for inviting us.
Thank you, Dr. Surveen,
Thank you so much, and all the best.
Yes.
And thank you, Dr. Jain.
Thank you. Thank you.
Thank you.
Thank you,
Thank you,
everyone.
sir. See you
Very
again
wonderful.
soon.
Dr. Anita, thank you. Dr. Jyoti, Dr. Deepti, Shweta, Bindu.
Thank you, sir.
Everyone,
Thank you.
Very nice discussion. It was a very excellent panel, and I think most of the questions on IUI have been answered.
Yes.
But
Yes.
even after this, if you are having any query, you can just post them on our numbers or on our mail. We will be happy to answer all the queries. Thank you.
And I would request all the delegates listening to us, please vote for Dr. Jain as North
Sure.
Sure.
Thanks.
Thank you.
Thank you. Thank you.
I will again thank Dr. Mala Srivastava, AOGD President, for providing this platform and having this AOGD webinar with all of us. Thank you. Thank you so much.
Thank you.
Thank you.
Thank you. Bye, Dr. Jyoti.
Bye.
Bye, everyone.